So let's welcome our Nobel Laureate Professor Ciechanover. Please. Nobel Laureate Professor Ciechanover, Chairman Uwe Morowitz, Academician Min-Chi Huang, Academician Huang, Chair Professor Long Bin Zhen, CEO of China Medical University and Healthcare System, and Vice President Zheng Jie and Vice President Xie. Distinguished guests and participants, welcome to the special lecture by our Nobel Laureate Professor Ciechanover. I now declare the special lecture open. In the beginning, I would like to invite Academician Min-Chi Huang to deliver opening remarks. Let's welcome our Academician Min-Chi Huang.
We'll go there? Maybe. Oh, okay, fine. Today was extremely happy that, the Chinese saying, or if you those for politicians, you don't want to say Chinese saying, you said the ancient people say that, 有朋自远方来，不亦乐乎, meaning that you feel in particular great that when you have a friend coming from very far. And so Dr. Aaron Ciechanover, and also this International Peace Foundation chair, and today the President Jiang Anshi, the president of China Medical University, because he was sick, he lost his voice. Therefore, I'm here on his behalf to welcome my friend Aaron Ciechanover coming to visit China Medical University. Aaron is a close friend that I think officially I had to introduce you. So you're from Israel, and then Taiwan and Israel has a lot of similarity. But I do admire Israel by reading your bibliography that the citizen in Israel has one voice, protect Israel. But in Taiwan, there are too many parties. You have a green color, you have a blue color, now you have a white color, and I don't know how in the future how many colors is that. So Taiwan need to learn this from Israel. So Dr. Ciechanover, that he received his MD degree from the Hebrew University of Jerusalem, and then after that, he decided he would like to know the mechanism of what causes the disease. So he has the Doctor of Science degree from the Israel Institute of Technology. It's called Technion, right? It's called Technion. And from there, while he was a student, he was already picked up a very important area that is a protein degradation. Because back to the old time, that everybody study how protein synthesis, how RNA synthesis, and so on. But we all know cell development and a lot of disease, the protein not only been synthesized, the protein, well, just like you drive a car, the new car can be old car, right? So the protein eventually will need to be degraded. But those mechanisms, at that time, people thought it's less important, but that's wrong. Because he has the vision that this is a very important area, and therefore, ever since he was a student, he was already studied that. And at the time when he finished his PhD degree, that he already very well known, because he already established the field that the protein degradation actually require multiple fraction, and it was require a small heat stable protein and so on. In addition to that, what I wanted to share with, to welcome him is, for the researcher inside our university or the student inside our university. Dr. Ciechanover has a very unique character. He picked up his vision, he picked up the area where he wanted a lifetime to study because it's an important area. So the other one is when he picked up the important area, he's persistent to continue. That, for scientific development, not every experiment working. So when you read the news, those are successful experiments. But while we do experiments, I think in the audience, many people all have that feeling that sometimes your experiment doesn't work. But as long as it's important that he insists and to really carry over and successful eventually. At the time when he's with a student, he's working on that related project, and eventually he got a Nobel Prize because he's a success. In addition to that, I also want to share with everybody one important character, that is teamwork. When you read his bibliography, he did not emphasize teamwork, but as a matter of fact, it reflected teamwork. He shared Nobel Prize, can you believe, that with his doctor mentor, and also with his mentor's friend. Then I remember that at the time that when Abby went to go to UPenn for the summertime, I think he's sabbatical there. Then after that, as a student in Israel, you every summer, or at least 2-3 summers, you went to UPenn, and because it's not easy that for a student who be able to work with a mentor and even working with a mentor's friend, and then eventually they all work together for multiple decades and get things done. And the field he studied, it is very important. Keep in mind that protein degradation, that's just like a gene regulation, like a metabolism. You have to synthesize, you have to degrade it, right? So many diseases, including cancer, including neurodegeneration disease, there are many proteins that originally we thought it's non-druggable because they are not cell surface protein. But now with E3 ligase available, even some of the protein inside the cell, which could be the cause for the disease, that can be now targeted. And all this knowledge was based on his multiple decade effort to tell us the proteasome degradation pathway. So today, that China Medical University is so lucky through the International Peace Foundation's effort that we will be able to invite Dr. Aaron Ciechanover that come to our university. And unfortunately well, I should not say unfortunately, but President Chung, because he lost his voice, he couldn't come. So for this welcome speech is on behalf of President Chung, and also our chairman of board, Dr. Tsai, who is in private university in Taiwan, chairman board is a very powerful person, and he's the person who support our university and hospital and the entire medical system to move ahead. And by the way, for Uwe, that at your university we have shared the same board of director. So with that, I'd like to welcome my friend to come to join our university. And this first time you visited this university. Oh, by the way, I have to say that he received a lot of awards, too many. And I don't want to count that. You will receive the Lasker Award, you will receive the Israel Award, you will receive the Nobel Prize, you were a member of National Academy of US, Germany, and Russian or different country, right? And now we even share. We serve in the same committee for Taiwan's Tang Prize. That I'm a committee member, but he's our advisor. So with that, let's do me a favor, okay? Big hand. When I say big hand, I really mean big hand to welcome Aaron. Wait a minute. Oh, I see. So after this, we supposed to take a picture?
Yeah, so we will take a group photo.
Okay.
First, and then I will welcome you again.
This one, after this, is this we give him?
Yeah, sure.
Right? We will take a picture.
Sure.
This is a
Yeah.
picture.
Yeah, that's right.
Look at me. 1, 2, 3. Look at me one more. 1, 2, 3. And one more.
So it's a great honor that we have this opportunity to invite Nobel Laureate Professor Ciechanover to deliver a special talk. Today he's going to talk about the personalized medicine revolution. Are we going to cure all diseases and at what price? So let's give another big round of applause to welcome Nobel Laureate Professor Ciechanover.
Maybe a bit more to your left.
It's okay? Yeah, they can hear me.
And here is, you can press. Next is this one, and this is like light.
Thank you. Okay, good afternoon, and thank you for coming. What I shall do, I shall divide my talk into two parts. The first part will be the short one. I'll tell you about our discovery, what really drove us, I will not go into any technological terms or the complicated biochemistry, just giving you the thinking behind. And then I shall go to the other subject, which is the main subject, and that's the revolution of personalized medicine, a little bit of historical perspective, but mostly of ethical issues that are related to what's going nowadays in medicine. So because I'm a physician, was trained partially as a surgeon. I'm coming from the medical world. The lab is involved heavily in diseases, studies, drug development, and so on. So the two subjects you'll see are coalescing somehow. So this is my city, the city of Haifa. It's a beautiful city on the east side of the Mediterranean. The medical school is here, and the hospital is here. It's an extensive hospital, a tertiary hospital of more than 1,000 beds. I don't know whether it's big or small in Taiwanese terms, but it's a wonderful hospital. And here you see the Baha'i Gardens, which is a UNESCO heritage site. The Baha'i people who were persecuted by the Iranians, by the Muslims in Iran, escaped Iran and built their center in Israel. They buried the leader, both the political leader and the religious leader in Israel, one of them in Haifa, under a beautiful temple that they built here on the side. Another one 20 kilometers to the north in Akko, in the city of Akko, and they are world experts in gardening, so the gardens are really gorgeous, and they are really going all along the hill. So let me talk first about protein degradation. So why at all we degrade proteins? Why we are not being born? You know, a baby is being born at the weight of 3 kilos, grows up, attains the final weight at the age of what, 15, 16, and then we continue to go with all our proteins until we end our life. Actually, we are replacing our protein in an amazing pace. We are replacing, on the average, about 5 to 7% of the proteins daily. Every day, 5 to 10% of the proteins are degraded and renewed. Some of them are replaced several times an hour, mostly transcription factor regulatory proteins like P53, MYC, JUN, FOS, and the others. Some are more stable, like hemoglobin, that lives for 120 days. But all proteins, with no exception, are turning over. Now, what is the purpose? Why they are turning over? One of the reasons is, of course, quality control. Proteins are very sensitive to all kinds of changes. Heat, for example, we don't realize that, but the temperature of the body, which is 37 centigrade, is deleterious to protein. Try to take proteins, all of you are working in the lab. Where you put it either in the freezer, in the liquid nitrogen, or in the deep freezer, and even if you work with it on the bench, you first put it in your ice bucket, and only then you put it in for the incubation, and then you take it back. Try to put a protein at room temperature, go to the butcher, buy a piece of meat, chicken, fish, beef, put it on the table for 1 day, and see what happens to it. The next day it's gone. What happened? The proteins got rotten, probably misfolded, denatured, stinking, and you have to kick it out. You have to throw it to garbage it. Proteins don't like even room temperature. They need to be. So how is it that our proteins are surviving for decades, for many decades in our body? They're not surviving. They're replaced all the time. So we don't know about it. We don't think about it. We know about it, but we don't think about it. But we are replacing our proteins all the time because of the temperature. Oxygen. Think about oxygen. Oxygen is deleterious to proteins. Actually, the two main drives of life, high temperature, 37 centigrade, and 21% of oxygen, which enable development of life on this planet, are also the most deleterious factors that damage proteins. So in order to evolve life, nature has to evolve side by side quality control machineries. Think about all the chaperones that are there, HSP70, HSP90, and so on and so forth. The ubiquitin system, other DNA repair damage. I mean, all the repair damage and all the destructive system were evolved side by side with life in order to assure quality control. Actually, 37 degrees was chosen, so-called, by evolution as the optimal temperature that drives all the biochemical reactions in the optimal way. If the temperature will go up by 1 degree, 38, you are sick. 39, you are very sick. And by 42, you can say goodbye to life. We are dying. 42, the lifespan of the body temperature is only 5 degrees, between 37 to 42. That's all what we got. And every deviation is a disease, even a tiny one of one single. And the reason is exactly, providing the optimal conditions, thermodynamic conditions, in order to run optimally all the biochemical reactions that are running our life. So oxygen, temperature, chemicals in the air, pollution, mutations, denaturing, misfolding, one reason why we have to replace protein. Another reason, control of processes. Take, for example, the cell cycle. The cell is moving from one stage of the cell cycle to another. In order to do it, proteins that run the different stages have to be removed and new proteins have to come. Cyclin A, cyclin B, all these cyclin-dependent kinases, cyclin-dependent kinase inhibitors. They are all assuring the right movement of the cell from one stage to another. If the process is aberrated, if there is dysregulated, what we get? Cancer, because the cell is dividing non-stop all the time without control. Transcription factor. Think about COVID-19. There was a transcription factor that led to transcription of the messenger RNA of the virus in the terms of immunization or whatever. When we were immunized, we don't need it anymore. So we put it in the memory of the immune system, but we have to destroy the transcription factor that was responsible for the transcription of the antibody. So even healthy proteins like cell cycle regulator, transcription factor, that we don't need them anymore, that completed the function, we remove them. And then, of course, differentiation and morphogenesis. Once we have the embryo, the initial stages, all the cells are identical, so they synthesize all the proteins. Once this differentiation starts, we don't want the brain to synthesize liver proteins, we don't want the liver to synthesize muscle proteins, and so on and so forth, so we have to shut them down. So you see that there are very good reasons why we need to destroy protein. And as was mentioned at the very beginning, people started to look at it, at the destructive mechanism, but not with a great enthusiasm. because destruction is much less attractive than construction. Of course, when you think about between the 50s and the 80s, you know, the really productive years of the evolvement of modern biology, people were busy with the central dogma of biology. Jim Watson just passed away a few weeks ago. DNA, double helix, transmission of information from DNA to RNA to proteins, protein folding, now, of course, AlphaFold, protein structure. This mesmerized the scientific community. Nobody could care less about protein degradation. Very few people did care about it, but of course, if you are working in a small country like Israel, poor, you don't choose the highway where all the sharks are driving the cars. You are taking a sideway where the chances of collision are much lower. So what was known about protein degradation? There was things that were known. I will not go into all of it. The lysosome was known, another Nobel Prize by Christian de Dive, a Belgian-American worker, a scientist, wonderful scientist that worked in Rockefeller University in New York, and he discovered the lysosome. And with the discovery of the lysosome, people thought that the question is solved, and the lysosome is working, however, in a non-specific manner. You know, the lysosome pinches off droplets of the cytosol, converts them into vacuoles, and the vacuoles are then pouring their contents into the lumen of the lysosome that is full with proteases, and all the proteins are degraded at the same time in a non-discriminatory manner. This was not what we were looking for. First of all, the lysosome was known. Second, we were looking, remember, for selective, specific degradation. We were looking for removing of proteins in a specific way. Think about that you have in the cell 1,000 molecules of a protein of the same type. Let's say hexokinase or RNA polymerase, doesn't matter. One get mutated or misfolded. You need to pull out this one molecule in the whole crowd and to leave all the other 999 intact. This cannot happen here because everything, all the molecules of the cytosol are included in this little bleb, and this lumen is full with proteins. Think about the stomach. Whatever you put in the stomach is degraded to amino acids, right? You know, doesn't matter how good the food was. In no time, all the enzymes in the gastrointestinal tract will degrade it into amino acid. The amino acid will be absorbed, and we shall build our own proteins. So, but people nevertheless notified that proteins are degraded in a specific way. Think about this table. Look at the half-lifetime, just a table of measurements of half-lifetime. Some proteins live only a few minutes. Some proteins are living many hours. Some proteins are living days, like hemoglobin. So how can it be that the lysosome degrades them when the lysosome is non-specific? So there was a prediction that proteins have another system to degrade them, but in a specific manner. Only misfolded or denatured. Only cyclin that has to be removed at a certain step of the cell cycle, and not all other proteins of the cell at the same time. So the cell needs to be intact. So not too many people, luckily, were in the field, and we assumed that this is going to be the case, and we presumed also, I was a graduate student at the time with Avram Hershko, we presumed also that there must be a step above the proteolysis of identification, that the protein must be identified before it's being grinded into peptides or amino acid. And only after identification, okay, this guy is denatured, let's take it away. This guy is not necessary anymore, let's take it away. Only then the grinding machine, the blender, is coming into action, and that's indeed what happened. And we discovered the ubiquitin system. I will not go into details. And the ubiquitin system indeed works in two steps that we predicted. We didn't predict that it will be ubiquitin. We didn't predict the biochemical nature of the step, but we did predict an identification step. So here is the protein to be degraded. Something must happen to it, so it will be identified. In this case, what happens, it's doubly phosphorylated. Why it's doubly phosphorylated? Because it's the protein that I like a lot. It's I-kappa B alpha. It's the inhibitor of NF-kappa B, of the transcription factor. It's doubly phosphorylated on two serine residues, and only then it is being recognized by a protein called ubiquitin ligase. There are about 1,000 ubiquitin ligases in the database. All I can tell you is that when I discovered the system, when I was a graduate student, and I went to MIT for my postdoc, I left behind about 10 different proteins that were needed to be in the test tube at the same time in order to degrade the protein. When the human genome was first unraveled in the spring of 2000 in a Nature paper, in April of 2000, the ubiquitin system was shown in its full landscape. 2,000 proteins. It's 10% of the human genome. This is the biggest family in the database. Not only for garbaging protein, now we know, but for doing also other things, because ubiquitin modification serves many questions, many processes. It serves quality control and cell cycle and differentiation and ER and autophagy and all kinds of processes in the cell. It's basically a new form of post-translational modification that I'm going to show you. But we came to it via asking a biological question, and I'll emphasize it in a minute. So what happens? A protein binds to E3. In parallel, ubiquitin, a small, highly evolutionarily conserved protein, is being activated by ATP, by an enzyme called E1 or ubiquitin activating enzyme, doesn't matter, jumps to another enzyme called ubiquitin conjugating enzyme, and jumps to the protein. And it conjugated covalently to the protein. This is the identification. Okay, ubiquitin is being tagged covalently to the victim, to the protein to be degraded. Not one time, but several times. First ubiquitin to the protein, second ubiquitin to the first ubiquitin, third ubiquitin to the second, fourth to the third, fifth to the fourth, and so on, to build a polyubiquitin chain, which is a degradation signal. For what? For an enzyme called the 26S proteasome. It's a mega protease of 2 megadalton, 2 million dalton, the biggest known protease in mammalian cells, and ubiquitin is the glue. Basically, ubiquitin is a molecular glue. It glues the protein. You see, it brings it closer. There are ATPases here, which open the protein. The protein is injected inside, and ubiquitin is being recycled back to bring more proteins. Now, the degradation is not to amino acid, but to peptides, and that's very important to mention. The peptides will be later on degraded to amino acid. These peptides are being recognized by the immune system, by the MHC class 1 molecules. Why it's important? It's important because all of you are sitting now in this hall with no masks. You are all immunized against COVID-19, for example. You're probably immunized against other diseases. You remember, I don't know which immunization Taiwan used. In Israel, we use 2 immunizations, 2 vaccines. One of Pfizer, another one of Moderna. They are both a messenger RNA based. What is messenger RNA? We are injecting a piece of messenger RNA that encodes one of the capsid proteins of the virus. This is being recognized as a foreign protein by the ubiquitin system. The ubiquitin system recognizes foreign proteins, being degraded to peptides. The peptides are being presented on MHC class 1 molecules, and here you get an immune response. We are immunized because we have a healthy ubiquitin system. So one of the many roles of the ubiquitin system is to present peptides to the immune system, to MHC class 1, beta 2 microglobulin system. If the peptide is coming from endogenous proteins and is recognized as self, nothing happens. But if it's a foreign protein, then it elicits an immune response, which happens in COVID. I got this winter, I took also an influenza immunization and others. Different immunizations are built differently. Some of them are still dead viruses. Some of them are still denatured protein. But the modern ones, the messenger RNA, are crossing the ubiquitin system on the way to the immune system. Many drugs were developed for the ubiquitin system. I will mention only one of them, a proteasome inhibitor. These are the active site of the proteasome inside the proteolytic site. And here is a case. Multiple myeloma, I will mention only one disease. Multiple myeloma is a B-cell lymphoma. You have a monoclonal expansion of a B-cell that generates one type of an immunoglobulin can be IgG, can be IgD, can be IgE, can be any IG, can be IgA. The disease was fatal when I was a medical student, fatal in agony, along very short period of time. It occupies, the B cells occupies the whole space of the bone marrow, pushes away the red blood cell line, the white blood cell line, the thrombocytes, leading the immunoglobulin that is secreted by the B cell, occludes the kidneys. People are suffering from renal insufficiency. The pressure on the bone marrow leads to basically to fractures. Actually, one of the typical complaints of the patients when they show up in the clinic is back pain. They come and say, oh, doctor, I have a back pain. And then the doctor say, go, I'll give you some muscle relaxants, go to do some physiotherapy. They come after a month, nothing helped. They are doing x-ray and you see crushed vertebra. You see a fracture in the vertebra, then you take a biopsy and you see, of course, the tumor that is occupying the entire space of the bone marrow, the long bones, the vertebra, the entire space. Here you see one patient, galloping level of IgA. Chemotherapy started, little response. The disease relapsed, and then an inhibitor of the proteasome, bortezomib, and to complete remission. This is one patient. Not all patients go to complete remission. All of them are responding now. And this drug, the proteasome inhibitor, changed the landscape of the disease in a big way. Now people are living 10, 15 years with high quality of life. Now what is the mechanism of action? Very interesting. It's not a chemotherapy. Therefore, it can be combined with others. What happens is that during the production of the immunoglobulin, some of the molecules are misfolded. Okay, you are making millions of molecules. Maybe 1% are misfolded. And these misfolded proteins are recognized by the proteasome, by the ubiquitin system, and should be degraded. If you inhibit the proteasome even partially, these abnormal misfolded proteins are accumulating, and they induce the unfolded protein response, which lead to apoptosis. It's not a chemotherapy, it's not a radiotherapy, it's not DNA chelating agents, it's nothing. It's a new novel mechanism. And therefore, it can be added to the already existing armamentarium in a synergistic way rather than in an additive way. Therefore, this drug was extremely important in the armamentarium, and there are many other drugs that are being developed nowadays, molecular glues. Here you have a bone marrow of the patient with multiple myeloma. You can see before treatment, 40% of tumor burden of malignant cells. After bortezomib, Velcade, almost normal bone marrow with all the normal precursor, less than 1% of malignant cells. So let me stop here. I will not go to others. Here you can see some other drugs. I will not go into it. I just want to sum up this this small introduction by telling you of course, the ubiquitin system has become now a mainstream for drug development, for research, a very important system. But I was lucky enough to see it from day one, from an idea that something like that exists at all. So we assumed that there must be a system to the discovery of the system. And that's what we did. And then other people say, there is a system. So many people came into the field. They say, there is a system that degrades protein. So Moshe Oren came with P53, and Yossi Arden came with EGFR. And many people said, maybe the protein that I've been working on for decades is degraded by the system. Then people started to make animal models, knockout, diseases started to show up, drugs came to the market, and the whole field is now really booming. So I think that I was lucky in a sense to see this development, and as a physician, for me it's clearly rewarding. I used to treat patients one by one in the operating theater. Now you can see that one drug can affect the quality of life of millions of people at once. Okay, now let's go to the other subject, and you'll see how the two are mingled. And I think that the other subject will talk to more of you, to a much broader audience. So, of course, we want to remain young forever. Maybe some of us want to remain beautiful forever, if they're already beautiful, at least in their own opinion. And we want to remain healthy forever. I mean, that's one thing that really concerns us. We want to cure all diseases, right? And there are many books on that, and people think about it. And the question whether it's at all possible. I don't believe it's possible, but let's talk about it, because there are something into this thinking. Think about people that were living about 120 years ago, 126 years ago, at the turn of the 19th century. You know how much they lived? 45 years, 50 years. You know what they died of? Any infections, any wound in the battlefield, delivery, blood loss, wounds, anything. They died of things that we cannot even imagine that people are dying nowadays. Why? Because there was no medicine at that time. Think 120 years ago only. You know, we know history of thousands and thousands of years, but 100 years, 20 years ago, no antibiotics, no surgery at all, almost no surgery, no X-ray. X-ray, if you remember, was the first Nobel Prize in physics, 1901, was given to Wilhelm Conrad Röntgen, right? CT scan, forget about it, MRI, who knows what it is? Nothing, no immunization, no vaccination, no nothing. Think about it. So people died of every single simple reason, and they, of course, lived 45 years. Now in a single century, we extended lifespan for 45, 50 to 85 in developed country. Taiwan is probably the same now. 60%, we added 60% in 100 years, where people didn't manage to add even 15 years in 4,000 years. Think about the old Egyptians, or the old Greeks, or the Romans that lived 4,000 years ago, or 3,000 years ago, they lived 35 years. They added maybe 10 years in 4,000 years, and we managed to add another 60% in 100 years, in 2.5% of the time. Amazing. What happened? Science, education, and technology. That's all. It's not the politicians, it's nobody. It's universities, knowledge, science, and technology. Vaccination, diet, X-ray, surgery, drugs, chemistry, whatever you want. So that's a miracle. Whether we are going to continue the same incline, probably not. We are starting to flatten. The prediction is that the lifespan will reach maybe 110, 115. There are already people that make it there. The centenarians are crossing 100 and are living, but these are very rare. We are succumbing to aging, mostly aging of the brain. Other people are talking about organs. Maybe we can implant organs, replace the heart, stem cells, and so on. That will be possible, but nevertheless, you know, remember the experiment with Dolly. Dolly aged very quickly because she got aged cells already. So we are still not there epigenetically. The brain, shall we be able to implant new brain to us? Well, that's a little bit of ethical issue, because if I get a new brain, then it won't be me anymore. So there are many issues here, but I think that we are going to flatten. There are many other issues, economical issues to life expansion, you know, who is going to work, are we going to work, who is going to keep us alive while we are demanding a lot of, we are going to talk about it, a lot of medical care and so on and so forth, but let's put this one aside. Okay, so let's talk about where medicine is going these days. Medicine is going in several directions. One is, of course, engineering. We are not going to talk about it. There are two types of engineering, what we call classical engineering, metal, bolts and nuts. I mean, we can replace the hip joint, we can replace the knee joint, we can replace valves in the heart. We still cannot replace the heart by artificial heart, I mean. We can replace it by natural heart. All attempts to build an artificial heart made of metal, of what, plastic, of whatever, failed so far. Nothing like that. There are some, what we call assisting devices that can maintain life for a few weeks, few months, but not something that you can go home and live with it for many years. So this is one type of engineering. Another engineering, we call it tissue engineering. It's not really engineering, it's molecular biology, right? So we are trying to replace the Langerhans islet, the beta cells in the Langerhans islet in case of diabetes, right? We want to make cells that will secrete insulin, but will be sensitive to glucose level. Parkinson's disease, you know, the substantia nigra par compacta is being degenerated. We want to generate cells that will be dopaminergic cells that will replace the cells in the brain. So this is one direction, cell engineering, but then there is also molecular engineering like CRISPR, right? So we are trying to take the same cell and repair the gene defect in it. We are trying to take away by CRISPR the sick part, the mutated part, and implant instead. There are some successes so far, mild successes mostly in monogenic diseases like spinal muscular atrophy, Duchenne muscular degeneration, but we are able to slow the disease, not to really stop it altogether, and so on and so forth. So this is what we call cell engineering or molecular engineering and so on. And surgery, of course, is always to our help, but what I'm going to talk about is mostly on drug development. So drugs have always accompanied us for a long time. So let's talk about drug development, and initially it was incidental. So, for example, aspirin was discovered basically by coincidence. It was discovered actually by the old Egyptians on the willow barks that grew on the banks of the Nile River. When they chewed the willow leaves, it was very bitter, but it was pain relieving. Already we have writing evidence for 4,000 years. The material was isolated by a German pharmacologist, by Felix Hoffmann, in Bayer company at the turn of the 20th century. The bitterness was removed by acetylating it, and we got aspirin. And here is aspirin, it's acetyl salicylic acid, and it became a magic drug for relieving pain, but not only for relieving pain, for relieving fever, but also in order to prevent coagulation of blood, so after myocardial infarction, and also to prevent inflammation, to attenuate secretion of cytokines during inflammation. And as you know, inflammation, chronic inflammation leads to cancer, so it became a preventive anti-cancer drug for people that have family history of cancer, mostly colorectal carcinoma. So aspirin was discovered kind of by chance, by history, and became a blockbuster drug. Penicillin the same. Penicillin was also discovered by chance by Sir Alexander Fleming, who got the Nobel Prize along with two other British scientists. Here is a Petri dish. Bacteria are growing. The Petri dish was forgotten by Alexander Fleming for a weekend, open on the table. Along the weekend, a fungal colony grew up. He came back on Monday, and he saw the fungal colony. Typically what we do, we throw this dish away. We don't use it anymore. But he noted there is a halo here that the bacteria don't grow into it. And he surmised that the fungus, the penicillium, secreted a material that he denoted antibiotics, anti against bios life. And indeed, penicillin was purified later on from penicillium, from this bacteria, from this fungus, and was used already during the invasion of the Allies in the D-Day, and saved the lives of hundreds of thousands of people already. People also learned the principles that fungi secrete antibiotics, and then streptomycin was isolated from streptomyces and so on, and the world has changed forever. So this was all coincidental. We cannot rely on coincidentality in science or in drug development, and the next step was marriage of two technologies, started in the 60s. One technology was synthetic organic chemistry. People synthesized different compounds, and on the way they isolated many intermediates. So there were libraries of millions of compounds in chemistry. For example, to synthesize artemisinin, which is an anti-malarial drug, there are 40 steps on the way. So you can isolate, intermediate A, B, C, D, and E, and there are huge families. And what people did in kind of a stupid approach, and on the other hand, there was modeling of diseases by tissue culture. Tissue culture was developed. We are able to culture cancer cells or cells that are coming from different diseases, cells that secrete cholesterol, for example. And people say, let's match the two. Let's have cells growing on microwells. Let's have millions of compounds with a robot that will put one material on each well and see whether the cells are growing or stop growing. If we are developing an anti-cancer drug, let's see which compound inhibits cell growth. If the cells are secreting cholesterol, let's see which compound stops the secretion of cholesterol. The idea was that there is no mechanism, we don't know anything, but of million compounds, one will found that do what we want it to do. And many drugs were developed by what we call high throughput brute force screening. One of them are the statins that inhibit the biosynthesis of cholesterol. They discovered by Akira Endo, a Japanese pharmacist that got the Lasker Award, the very prestigious award for it, and he screened the library of Japanese plant products against cholesterol biosynthesis, and he found one statin, and statin became a big blockbuster in order to prevent cholesterol accumulation here. You see the yellow plaque in the coronary artery that brings blood to the heart itself. Okay, but then people said that's not enough. That's not enough because all what we are doing are modeling. We are working on cells, we are working on mice, and indeed, when we look at patients, sorry for that. When we look at patients, we see that if we have a group of patients one day that are coming to the clinic with the same disease and we start the gold standard treatment, some of them will respond and get cured, some of them will become chronic, and some of them will unfortunately die. And people didn't understand why is it, what is going on. And the reason is that despite the fact that they have the so-called same disease, it's not the same disease because there are not two people that walk on the face of Earth that are identical to one another. You may argue that I'm wrong, that identical twins are identical to one another, but they are not identical to one another because once they start their life, epigenetically, they start to change. We are men and women, children and adults, fat and thin, living in different cultures, inherited from our parents different genetic repertoire. We are different from one another. Not two people on the face of Earth are identical to one another. And I think that therefore we realize that the modeling that we are using, even in screening, is wrong because we are working on the wrong model. The right model is the human being. But how can we get access to the human being if we cannot read the information that code the human being? And of course, the revolution started with these two people, with Jim Watson and Francis Crick, who discovered the double helix and the mechanism of replication and transmission of information from DNA and later to RNA and to proteins. And the drugs of today are going to be based on our DNA in many ways, not all of them, in many ways. We are moving actually from one size fits all, that if a woman is coming with breast cancer, let's take the breast away, irradiate her, give her chemotherapy. We are moving into personalized approach, into suit tailoring type of medicine. We are going to tailor the treatment to the disease in an individual that has a name and ID number. And that's exactly what I told you. You see, we have a group of patients here. They are here colored with green, blue, and orange. And they all have the same disease, let's say breast cancer woman or prostate cancer. And once we send them on the way with the gold standard, they behave differently. Some of them are, unfortunately, we put an X on them, and some of them are being cured or become chronic. The question was, we couldn't predict it. We started the treatment and it was all about statistics. We wanted much better tools to predict what is going to be the disease course. And let's take just breast cancer as an example. Let me just take a sip from the bottle, otherwise I'm going to die of thirst. So you see here two women with, what happened? Okay. With breast cancer, you see the biopsies, and the biopsies looks already different. You see here is the tumor. Here you see different islands. But you see coloring. This is colored and this is not colored. The color is artificial. We colored, the pathologist colored the tumor with an antibody to mutated estrogen receptor. This antibody stained the tumor cells, while the same antibody didn't stain this biopsy. It means that this woman has a mutation in the EGF receptor. So this woman can be treated with tamoxifen. But this woman should not be treated with tamoxifen, because if we'll treat her with tamoxifen, we shall waste not only money but also hope, and she will continue to deteriorate. So now we start to stratify. There is no tumor in the breast. Until a few years ago, it was breast tumor. If there were no metastasis by imaging, we took the breast away, we started preventive chemotherapy, radiotherapy, and that's it. Now we are stratifying the disease according to the mechanism behind. So what this woman might have, she might have a mutation in some other protein, maybe in the EGF receptor. And therefore, she should be treated with Herceptin that clusters the mutated EGF receptor and send it to degradation via the ubiquitin system, but this time not by the proteasome, but in the lysosome. But maybe she has a mutation in the progesterone receptor. So it's another type. But maybe she doesn't have a mutation in any of them, and then unfortunately she is being called triple negative. Triple negative means that we don't know, but she has cancer, so we must know. So by screening, we are going to get into this type of woman, into the triple negative, and we are already there. The prediction is that there will be more than 10 different types of breast cancer that each should be treated according to the underlying driving mechanism. That's the idea of personalized medicine. Personalized doesn't mean that every person on the face of Earth will have a different disease. Personalized means that out of all the women that get breast cancer, there will be 10 different types of them that should be diagnosed before we start the treatment. And the treatment is going to be very precise, with much less side effects. It's going to be a missile to the target. We are not going to mutilate the breast. We are not going to put chemotherapy with hair loss and side effects. We are going to hit directly the mutation. That's the idea in personalized medicine. It doesn't mean that the 10 million women that are going to get breast cancer next year in all the world are going to have 10 million different diseases. No, but they are going to have 10 diseases with different frequencies, of course, of each. But now we have the tool by DNA sequencing and antibodies and so on to diagnose what each of them has. So that's what I told you. The whole story started from our variety as a population and from achievement which is now available to everybody, because initially we sequenced the first genome, and the first genome took about 10 years, almost 10 years, and more than $1 billion. Now we can sequence the whole genome in no time for no money and really get, and we don't need really to sequence the whole genome. We can do like oncogene search and so on. I will not go into all the technicalities here, but we in the scientific and the medical community can read now easily and at very low price the code that make us what we are, and then identify the aberrations in the code that are leading and resulting in diseases. So that's the story, and for each disease we are doing thousands of sequences in order to build a map, how many types of each disease we have. And now, with the aid that came from very different directions, we can design and develop drugs much faster. Think about AlphaFold. AlphaFold came from a different direction. Now we can predict the structure of a protein with a punch of the keyboard. So if you have a mutated protein, I can get the structure not by crystallization that take years, but by predicting it via a software that is available. Once I have the structure of the protein, I can now, via computational chemistry, design drugs that will dock into the protein and will inactivate its deleterious activity. Of course, at the end, I will have to go to the lab, to a mouse model, and then to clinical trials to try whether my predictions are correct. But nevertheless, I can shorten the way and the pricing big way. Think about COVID-19. COVID-19 took 9 months from the beginning of the epidemic to the first person that got the shot, by sequencing, by synthesizing messenger RNA, and by giving it. So think about how quickly we were able to show the way. In this case, we didn't need any protein structure and so on and so forth, but it doesn't matter. So we are building a genome atlas of all the mutations. All the mutations will be modeled. According to the modeling, computational chemistry will walk in to find docking molecules, and the road is open. So this is the roadmap that we are currently in it. Okay, so let me talk a little bit about the ethical issues that are involved here. I will not go into all of them. I will talk only about 2 of them. One of them is the end of the blockbuster drugs. The pharmaceutical company hate it. Why? Because now, you know, for atherosclerosis, they sold one drug, statins. Now there are many other drugs already, and the market slice is going to be much smaller for each group of diseases. So until now, all the patients that went through heart attack and had high level of cholesterol took one drug. So the company made billions and billions of dollars. Now if we are going to find that high cholesterol level is being caused by 7 different reasons, and each will have its own drug, then the market will be sliced into 7 different pieces of cake. And for each piece of cake, the companies will need to make a new drug, and the drug will make only 1/7 of the price that the original drug made. So the companies hate it, of course. The blockbuster era is going to end up, and of course, they are not happy about it, but that's the way science is going. But that means that the prices of these drugs are going to hike, which is going to mean that medicine is going maybe to be less accessible to people than it used to be. And that, for me, as a physician and as a human being, is unacceptable. But think about this one. Another issue is, of course, bioethical problems of availability of genetic information. Think about genetic privacy. You're now going into a hospital, and in the hospital they are sequencing your DNA, and it's being kept in a computer, and somebody hacks into the computer and calls me one day and says, hey, Aaron, you remember that you were in the hospital for chest pain a few years ago and your DNA was taken? And I said, yes. And you know what discovered there? It discovered that besides that you don't have any cancer-causing mutation, you do have a mutation in APOE4, which causes Alzheimer's disease. And if you are not going to pay us ransom of so many dollars, we are going to put it on the network. So this information is extremely sensitive. But it's not only sensitive for hackers, for criminal reasons, it's also sensitive to the patient. You can imagine that I came to the hospital with a chest pain, and they wanted to rule out myocardial infarction or heart attack, and they sequenced my DNA, and they found this mutation in APOE4, and the doctor comes to me and says, hey, Aaron, you don't have heart attack, but you have a mutation in APOE4. Then what do I do with it? I go to my wife and tell her that in 5 years I'm going to succumb to Alzheimer's and I'm not going to recognize her anymore. I'm going to my children to tell them that they may carry the gene. I'm going to my employer to tell him what's going to happen to me. I'm going to my health insurance that will be revoked if he will hear that I'm going to have Alzheimer's, and now he will have to pay for my institutionalization, and so on and so forth. Think about the implications of knowing the future. That's the issue, main issue, in my opinion, of personalized medicine. I don't know if you remember, I'm sorry that I didn't put another slide, but there are 4 P's, 4-letter P to personalized medicine. It's personalized or precise. It's preventive, because if we know about something, we can do something to prevent it. But it's also predictive. It can predict the future. On top of it, it's also participatory, because the patient will now play a much more important role in decision-making process about his or her future, if they can, of course, intellectually, but let's forget about it. But the idea that you can predict a disease now based on the DNA is dangerous, because until now, you know, tomorrow when I'm leaving Taiwan, I'm flying to Singapore, and the airplane can crash. It happens, right? But I don't know about it. So I nevertheless am going to take the flight. And if it will crash, there will be half a moment of, and then it will end up. But I think that the turning point of personalized medicine is converting it from present medicine to future medicine. And we as human beings are not equipped with psychological tools to handle the future, especially not a bad future. So that's the big turning point. And I'll show you in a minute what's going on. And of course, the criminal world, be prepared for the big genome leak. And I'll end up this part with Angelina Jolie, that was informed, or was not informed, that noticed that her mother is dying of ovarian cancer, and her aunt, the sister of the mother, died of breast cancer. And she's an intelligent woman. She consulted the doctor, and the doctor said, wow, maybe in the family you are inheriting the BRCA1 gene, BRCA1, breast cancer number 1, which is a driving gene, oncogene, for both ovarian cancer and breast cancer. So maybe you, Angelina, go and test yourself, because you may carry the gene that you inherited for your mother and was in line in the family because your aunt also got this cancer. She was found positive, and she did 2 surgeries. One, she removed her breast, and the other one, she did oophorectomy. She removed her ovaries in order to remove a ticking bomb from her body. So again, this is Angelina Jolie. By announcing it, she did a great service to the community, but she didn't solve the entire problem. First of all, she's not afraid about health insurance. She's covered. She made enough in her life. But what about her children? She has children. What do you do with the children? And so on and so forth. So there are always issues that are being opened here. The idea is, of course, that I'm not here to frighten you, but the idea is that in science, science is able to solve problems. That's the notion of science. But in order to solve problems, science needs to know what is the problem. So in order to answer a question, we need to know what is the question. So now the question is identification of BRCA1 carriers and what to do about them. There is CRISPR in the, behind the corner, gene editing and so on and so forth. But again, science is moving from question to question to question, and I think that Angelina Jolie exemplifies it. Let me take the last 5 minutes, because it's a medical school and I'm a doctor. I'm not a doctor really. I'm not curing patients anymore. I'm a physician. I am a licensed physician. Let's put it this way. So in medicine, in medical school, and in the hospital, there are patients. And the 3 pillars of medicine are the patient, his or her disease, and the treatment. That's what we are studying in medical school, right? That's all. Pathology, microbiology, pharmacology, everything is being channeled into those 3. These 3 pillars are going to disappear. Medical education and physicians are going to be completely different in no time. And I want to show you why and how. And we should get ready for that. Diseases. The old disease was monitoring pulse, blood pressure. The baby is crying, the nun is holding it. Here is the old doctor. Look at the old hospital. New medicine is going to be molecular. The diagnosis is going to be in many ways molecular. We will not need, of course, sophisticated imaging and so on, but we are not needing all these old low resolution devices. Think about this one, the definition of disease. I talked about it. APO4E, I just told you about the gene that causes Alzheimer. Newly developed blood tests can detect cancer, not only cancer. I can tell you also that there are now biomarkers to Alzheimer. 4 years before conventional methods. Let's say that I'm taking now biomarker for cancer, and people tell me you are positive for RAS mutation or for P53. I'm healthy. Rita, I'm talking to you, I'm walking on the podium, I feel very healthy. Am I sick or am I not sick by carrying a P53 RAS, MYC, I don't know what, mutation? What is the definition of the disease? Until now, disease was something very simple. You cannot get up in the morning to go to work because you feel bad. This was a disease. You don't feel good. Mutation in residue 11 of RAS is a disease or not? We don't know. And it's important to know. It has insurance implications, it has family implications, it has diagnostic implications, treatment implications, all the implications in the world. And what do we do about it? So think about disease, and the patient. Why should we wait to somebody to get a heart attack if we can treat the sperm, we can treat the egg, or maybe we can treat the young embryo when it's 2 cells, 4 cells, gastrula, blastula, morula, or already an embryo. Why we have to wait for decades to develop cancer if we can prevent it ahead of time and treat it? So think about it. I'm not telling you what to do and how to do, but I can tell you that the 3 pillars of medicine are going to be different, and the treatment is also going to be different. Think about CRISPR-Cas and gene editing. So I think that I lay my case here, rest my case here. I told you a little bit about what we did and what we do. Since I'm very much involved in medicine and I have medical students, MD, PhD students, we are also developing personalized medicine diagnostic tools for ubiquity and related diseases. So for me, at least, the 2 subjects are kind of almost one. And thank you very much for your attention.
So next, I would like to invite Academician Min-Chi Huang to host the question and answer section.
Okay, thanks, Aaron. That is a very inspiring.
Can I sit over there?
Yeah, please, whatever you feel comfortable. This is Taiwan. Taiwan is a nice place. And he need a.
Thank you.
Okay, I have a lot of questions, but today the rest of time is yours. So I would suggest that you have a question, please raise your hand, then I'm going to identify. Okay, the first one. First one, second one, third one. Yeah, go ahead. You.
I cannot hear you without a mic.
And I also suggest that identify yourself, Aaron. I have a joke that I'm kind of official joke. So occasion like this, if the student and postdoc fellow do not ask questions, I close the door, say you cannot go out for dinner. So you have to identify yourself, especially if you are student and postdoc fellow.
I have this one. Sorry.
Okay, yeah. Thank you for a great talk, Professor. I'm the graduate student in CMU.
Graduate student ask questions, so you are allowed to leave later on.
Thank you. So my question is, you previously mentioned personalized medicine promises the greater efficacy by tailoring treatment to patients, right? But I was thinking, take breast cancer, for example, we will classify breast cancer patient into luminal A, luminal B, TNBC, for example. So that's the first round of diagnostic marker screening. But after treatment, I was thinking have things like metabolic reprogramming will occur, right? So maybe those patients need the second or third round screening, omics-based screening. So in your opinion, how can healthcare system and insurance models realistically balance the cost of mutation screening and target drug development with clinical benefit and sustainability?
Yeah, the question was about, no, I have a microphone here. The question was about screening, and that's a very complicated one. The ideal thing will be to screen, but screening has a lot of problems in it. First of all, mutation can appear along life, so you have to screen people every year. And then the insurance company don't like it because the screening is very expensive, so they prefer that you'll get sick, they'll treat you. Rather than screening 1 million people to get 10 patients, they prefer to treat the 10 patients rather than screen every year 900,999. So, so this is one. And again, you have to do it repeatedly. So I think that the current policy is, but again, it's not adopted by every country, that you are screening those people that have family history. So in the case of Angelina Jolie, if you have a family history of breast cancer, not only one single case, your mother or your grandmother, and ovarian cancer, then it's better for you to do BRCA1. If you have a family history of colorectal carcinoma, you may have polyposis, familial polyposis, which is a polyps in the colon, and then it's better for you to go to do colonoscopy. So the doctor will tell you whether you also carry polyps and you are prone to colorectal carcinoma. So the idea will be to do screening if you are rich, and that also depends on the insurance health program that the country holds. Israel has a very good, well-advanced health insurance. Everybody is insured. Doesn't matter whether you pay or not, and everybody is entitled to the same service. Of course, since I can afford, I buy extra services, but the basket, the basic basket, is common to everybody, and you can get it. You know, for me, they take out of my salary, but for people that are poor and cannot pay, they get anyway what I get. So again, I can buy, because I'm not rich, I'm well-to-do, I can buy extra, and I can go every year to periodical checkups. So I do, you know, bicycle and ECG and this and that in order to make sure that beyond the basic health program, I'm also okay. So again, screening is very, you know, very questionable, though ideally it's the best, because it's always better to prevent a disease than to treat a disease. Always better. Or to catch it when it's very early. That's always the case, but again, the pricing, the repeatability, the affordability are kind of prohibitive. So I think that for now, it's being kept for susceptible people that have history of the family and so on. So it's limiting the expense of the health insurance system and so on.
Okay, so you got the answer, right? Okay, so Nevi?
Thanks for your wonderful talk. I am a PhD student in China Medical University. So my question is about the cellular heterogeneity. So
About what?
Cellular heterogeneity.
Cellular?
Heterogeneity.
Heterogeneity,
Yeah.
not homogeneous.
Ah, okay, right.
So the recent studies from Avi Brega from Gene and Tech shows the every cells behave different even though they share the same genome. But we still don't fully understand how these cells interact with each other, particularly in the specific time or spatial context, and what signals they will share between each other. So these are highly unknown. So from all this, my question, how we can use this complex information to build the personalized medicine for particular patients?
Well, I'm not sure that I'm going to answer right your question, but you're right. You know, to our dismay or surprise, we discovered the tumors, for example, are not homogeneous, and the tumor cells are heterogeneous, and therefore we came to do not only single cell omics, but also spatial omics. So in the tumor, we are defining zones. That complicates the treatment big way. But I think that at the end of the road, the tumor as a whole has a soft belly that we need to identify. So you are going to the weakest point. It can be the cancer cell, it can be the mutation, it can be RAS. People are trying very much to drug RAS that until recently was undruggable, but now it becomes partially druggable. To touch the microenvironment that has nothing to do with the tumor cell, it has to do with the microenvironment. There was Yuda Folkman at Harvard that went to the vascular system and find the antibodies to VEGF. Yes. So, you know, we now have a drug that is in trials now that is starving the cell. It's shutting the ubiquitin system, and it's starving the cell for recycling protein, not providing them amino acid. So the tumor cells are much more sensitive than the healthy cells to the lack of amino acid, recycled amino acid. So I think that the issue is to discover the soft belly that will affect, the group of cells. I'm not saying that we are going to be successful, but you cannot attack. There are million different forms of cells in each tumor, in each individual. How can you handle it? So you are trying to find, and remember also one thing, and Minchi is much better than I am because he is more into cancer. Cancer will never be treated by one drug. Forget about it. There are very few cancers that are treated with one drug. I can tell you, premyelocytic leukemia, maybe 2 drugs, RARA, retinoic acid and arsenite trioxide, came from China. Maybe testicular cancer by methotrexate. But that's it. All the rest need a combination of drugs in order to attack different mechanisms. And nevertheless, the cancer via dormant cells is coming back. The patient can be completely disease-free. No cancer for 5 years, nothing. You cannot discover a remnant, and all of a sudden it erupts. Why? Because there are dormant cells that we still don't know where they are, why they become dormant, and who wakes them up. So you see, it's very complicated. We are trying to do what we can, and I think that currently the notion is to go to the soft belly. Several drugs go to the soft belly that affect, the entire tumor.
Yeah.
But,
Okay.
The discovery of variety of cells was shocking.
So I know you're the third one. So can I just address both of your questions? That the response regarding to the screening, that let me use a BRCA1 as an example. I remember before the PARP inhibitor available, it's a BRCA mutation, and now there's a drug to treat it. But before that, there's a debate. Say, okay, this family has a BRCA mutation, but in MD Anderson, we decided to, all their relative family, should we screen it? So at that time, there's a debate, because at that time, there's no drug yet. So the issue is, after screening, then if you are positive, what are you going to do? You have no idea, you have no drug. So a situation like this could be slightly different, but now with the PARP inhibitor available, now even the BRCA mutation positive patient, there's a drug to treat it. But however, back to his question, remember that everyone just mentioned about the combination. A single drug is going to be very difficult to treat cancer. So combination coming from, like if I use the BRCA as a mutation as an example, now you have a PARP inhibitor, but PARP inhibitor response rate is only 50 to 55% response rate. The rest of the patient not respond, right? And when those patients who do not respond, they have different mechanism cause resistance, and that will come in for different kind of combinations. So that may be partially answer your question too. So with that, then your question, say.
Okay, thank you very much for the exciting talk. I'm a clinician in rheumatology in this university hospital. My question is about lysosome protein degradation. I'm studying the hydroxychloroquine-induced retinopathy, where the lysosome autophagy impair. Okay, do you think enhancing proteasome, this pathway can compensate for this impairment? Thank you.
Yeah, very good question. I simply didn't have time, but if you think of pharmacology, you're a physician also?
Yeah, he's a physician.
So think,
He's my classmate too.
Yeah, you already said it's in neuropathology. So, if you are taking a textbook of pharmacology like Goodman-Gilman and so on, it's mostly about inhibitors, right? Pharmacology is an antagonist. Yeah. That's the world. Very few agonists are coming. Maybe in hormone treatment, we have agonists, but typically, big pharmacology is an antagonist, antibodies. Think about the whole cancer, all the MABs, that are all antibodies that are neutralizing. Think about hypertension, beta blockers. Yeah. Think about, I don't know what. I mean, so kinase inhibitors, the IMIBs. I mean, in the ubiquitin system, it's the opposite. We want agonist. We want to activate it. And so what we do is, not we. I mean, when I say we, it's not me. People are developing it already. There are two types of agonists. They are basically sitting under one umbrella. They are called protacs and molecular glues and IMiDs. They're already in use. In multiple myeloma, I didn't mention them, there are two very effective, one group of agonists of the ubiquitin system, lenalidomide and pomalidomide. Yeah. They're already in use, in very successful use. Actually, they are inheritors of a drug that you know very well about, thalidomide. Thalidomide was a drug that was given for women, pregnant women, that had morning sickness. They had nausea and vomiting during pregnancy. And it was forbidden by the United States FDA to get into the United States. It was made by a Swiss-German company. And in Europe, they noted that the babies that are being born are, for women that took thalidomide during their pregnancy, they have unbelievable defects. They are missing limbs. They have syndactyly, fusion of fingers. They are missing legs, and it was horrendous. About 3,000 babies were born with defects until people linked it to thalidomide. And thalidomide was buried, but then the United States, the NCI, the National Cancer Institute, in a repurposing project, found that thalidomide is the best killer of lymphocytes. So, from a different reason, which I'll tell you in a minute, and then they put thalidomide back into the market, but under huge caution that even a pregnant woman that walks 10,000 kilometers away will not smell it. So, and then they developed novel derivative to thalidomide, lenalidomide, pomalidomide, and so on and so forth. And these molecules are molecular glues. They activate the ubiquitin system. How? They are glues. They take a ubiquitin ligase, this E3 that I showed, that ubiquitinates proteins, and they take a target substrate that is the driving force of the malignancy. So they take Z-finger protein in multiple myeloma, they can take RAS, they can take everything. So thalidomide has two heads. One binds to the protein that you want to get rid of, the other one binds to a ubiquitin ligase, and they bring them together. They match-make them. Once the target protein is close to the ubiquitin ligase hits it with ubiquitin, and the proteasome takes it away. This is the biggest industry nowadays in many, many companies. There are tens of companies that are trying to develop what they call protacs, proteolysis targeting chimera. Chimera is this Greek monster that has two heads. You need two heads. One head binds to your target protein. Potentially you can degrade any protein. Think about all the neurodegenerative disease. That's what they do. Think about tau in Alzheimer. Think about SOD in ALS. Think about Huntington in Huntington. All these mutated proteins. Think about all the neurodegenerative diseases have one common hallmark, which are aggregated protein. So you need to find the high affinity binder to the target protein. Then you have to bind it by a linker to a binder to ubiquitin ligase, and bang, you have a drug. This is the new wave now that medicine is doing. So yes, now I'm coming to the answer to your question. The answer is yes. We are able, in principle, and there are already drugs in the market, to activate not the proteasome, but the ubiquitin system and the proteasome in it. Actually, Minchi, for you, the first drug, except for thalidomide and lenalidomide that were discovered in retrospect, is coming to the market. It's a degrader of the testosterone receptor in prostate cancer, coming by an American company called Arvinas, that was founded by a good friend of mine, by Craig Cruz at Yale University. So it's already a movement. Yes, developing agonist, not antagonist, to the ubiquitin system. Sorry for the long answer, because it required explanation of the mechanism.
Yeah. I'm glad you mentioned that, because you originally studied lysosome degradation, right? But as long as you know the target, then ubiquitin now, and you mentioned about 1,000 E3 ligase, right?
Yeah, 1,000 E3 ligase.
So keep in mind, the market is huge, because the new technology everyone just mentioned is PROTAC, right? So used to be, we induce antibody to target the cell surface protein. So a lot of protein inside the cell, we thought it was non-druggable. But now with the E3 ligase, available that you could target that particular intracellular protein, then link it to an E3 ligase to bring them together, such as thalidomide, right? Then in such a way that the therapeutic target protein originally is non-druggable, now it becomes druggable. Then you can degrade it by using E3 ligase. And at the time when he studied the mechanism for this ubiquitin degradation E3 ligase, we were not thinking about disease at that time. But apparently, all these mechanisms turn out to be extremely useful. I'm predicting that the PROTECT technology he just mentioned is going to generate a large number of drugs in the future. Because it used to be everybody targeted the cell surface, EGF receptor, HER2, c-MYC, right? But now intracellular protein is drug targetable. It's targetable. Question? Okay. 1, 2, and then 3. You go first. You go first. 1, 2, 3. Yeah.
Thank you. Thank you, Professor Ciechanover, and very inspiring talk. In every Nobel Laureate they were awarded is because of their great contribution and their groundbreaking finding which change our life, right? So some of these groundbreaking finding is easy to convince people to believe, but I believe more this old groundbreaking finding initially is very unexpected and it's difficult to convince people. So I don't know whether you have some kind of experience, and in this situation, what we will do.
What?
The original that everybody think about lysosome, right? But and then the people kind of neglect the degradation. But the degradation is
well, in retrospect, yeah, there was little attention paid to us at the beginning, which was good because basically it let us have few years to work quietly with no disturbance. You know, if we would have been working on DNA, we would have been crushed. So by all the giants. And indeed, the first paper was published in a very low impact factor periodical in BBRC. But at that time, I can tell you that there was no impact factor. People didn't know about it. There were no computers. You know, there was, at that time, every Friday, I didn't work in the lab, and I went to some place that doesn't exist anymore. This place is called library. You know, there are no libraries anymore. There was a big library, and I pulled down all the periodical that came during the week, JBC, JCB, PNAS, whatever, and I was looking for papers, and there was Index Medicus at the day. I don't know if you know what is Index Medicus, that summed up all the papers under keywords, and there was current contents, and I used very non-sophisticated tools in order to follow the literature. These were fun days. Nowadays, it's much easier. You don't need a library because you have a library in, where is my cell phone? You have a library in your cell phone. You just push in PubMed and you know everything. It makes life simpler. The search is made simpler. But I think, let me just sum it up. The work that we did was all biochemistry. There was no molecular biology. I can tell you that today, we couldn't have discovered the system. If the system was not there until now, and I was entering the field and using now genetic screening, no way I could discover the ubiquitin system. Why? Because let's say that I would have used a genetic approach, screening mutational analysis, doing CRISPR screening. So there are 2,000 enzymes, and many of them are dependent on one another, okay? So E1 and E2 and the E3 and then the deubiquitinating enzyme and so on. And let's say that you shut the system down. Okay, you screen for no proteolysis. Okay, and you get an enzyme. You get all of a sudden E3. What do you do with it? How do you know where it belongs? How do you know that there is an E2 above and a proteasome below and a recycling enzyme in between? We used canonical biochemistry for reconstruction. The only way to know how a mechanical watch is working, the only way to understand mechanical watch is to take a screwdriver, to take the watch into parts, to put it on a cloth, and then to put it back. If you put it back correctly, then you know how it works. That's what we did. We use columns, chromatography, everything. We put everything in separate test tube, and then we put everything back together. We measured kinetics to know who is A, who is B, and who is C. Because if you put C before you put A, then you still need A to activate, so you have a lag time. We use very primitive methods in order to reconstruct the system. But as far as I know, and I understand modern biology, and I do modern biology in my lab now, using modern biology can never discover the ubiquitin system. You need to really do it via, reconstructive biochemistry. So as primitive as it is, this was the way. If you inactivate it by mutation, by irradiation, by CRISPR screening, by I don't know what, you don't know where it belongs along the cascade.
I think this is a very important question, that your next question, right? So while you're picking up, I want to add a few things. Because this relates to your earlier question that you made, because in the disease you study, the degradation is from lysosome. But at the time when he started, with another degradation, ubiquitin degradation pathway, and there are people who already study lysosome degradation. I don't think those people kind of resistant that, but they use the very solid, fundamental biochemical technology, and as he pointed out, the fraction by fraction, then by putting together, you see the functional recovery. In this way, they discover ubiquitin protein, they discover E1, E2, E3, and so on.
By the way, for your question about the lysosome, if you are labeling cells with methionine, let's say that you are putting S35 methionine, you are pre-labeling cells. Okay, and then you are chasing them. You're doing a simple pulse chase experiment, and you are putting a lysosomal inhibitor, okay, like chloroquine or ammonium chloride or pepstatin or whatever, no inhibition. The lysosome doesn't take care of intracellular protein degradation in a big way. There will be very little inhibition. Most of the degradation of cellular proteins is ubiquitin.
Okay, so your turn.
Okay. The lysosome is mostly planned either for stress, for macroautophagy, or for taking protein from the outside via clathrin-mediated endocytosis.
Okay, you and then?
Yes, here, the girl here.
Thank you for a wonderful lecture, Professor. My name is Joy. I'm a PhD student in biomedical science, and I have a question about what is your vision for the future of AI in precision medicine? Thank you.
Okay.
Yeah, well, I don't think that I'm any smarter than you are. Not you, all of you. AI for me is a tool. I'm using AI in the lab now. We are using it a lot for screening slides in pathology and so on. It's a tool, very smart tool, that needs to be regulated, of course, in order that it will not be harmful. The question, it's very helpful in science and in prediction, in building prediction of molecules and so on in computational chemistry. There is an issue now that is coming up, which I am opposing, but maybe because I'm old, writing papers by AI and reviewing papers by AI. I am proud of myself. If AI will write my paper, why am I existing? Just to do the experiment? I'm very proud of my writing. I'm very proud of my being critical of what I write, of reading it again and shaping it and polishing it. And I'll give you an example, but that's a matter of taste. It will go there. People will write by AI and review by AI. Do you want your papers to be reviewed by a machine? I'm not sure. I did an experiment, and I asked AI to write me a review on the ubiquitin system. Right? I wrote myself many reviews. I asked AI to do it. Perfect review. All the references, one by one, by date, except that it was the most stupid review I ever read. Why? Because the AI could not bring the logic of why we moved from experiment A to experiment B, and why experiment B led to experiment C. It was a summary of the papers. It took basically the summary of all the papers. So if you want it as a literature, bibliographic base, it's good. But I can go to PubMed and to find all my papers. I don't need AI for that. But it didn't have the power of logic to explain me what drove us. Therefore, AI could never get the Nobel Prize that I got. Never. Because we designed the experiment according to the result, and AI couldn't do it.
There's one more
Thank
question
you,
there,
Professor.
right? Okay, then I'll fill the time. Oh, you already microphone. Okay, so can I just mention that about AI? Yeah, AI is very good for you to collect information. But if you want to design an experiment, you want to ask a biological question, that question has to come from you, not come from AI. Yeah, go ahead.
Maybe one day I will get a Nobel Prize, I don't know, but not mine.
Yeah, I'm Ellen, and I used to be a surgical resident in south of Taiwan in Chang'e Memorial Hospital, and now
So you're a surgeon?
Yeah.
He's a surgeon too.
And now I turn to basic research. And I think that personalized medicine is more and more important. And in the past, we use physical examination and history taking to diagnosis and differentiation. And I think that maybe in the future, genetic research is more and more important. And maybe AI research could find more and more protein structure possibility, more possibilities, protein structure in the human body, and we could find this different structure of protein to get more and more drug or medicine or somewhat. I think that.
So what I didn't.
I think
yeah,
what
you're right.
I think you're going to use AI to predict the tertiary structure of the protein and so on, right? And that's for help you the drug development. Am I correct?
That would help us to find more and more mystery structure in a protein or something.
I think that he doesn't against that. Right? I mean, what he says is, for example, use AlphaFold 3 or alpha, and then to predict using the primary sequence to predict the tertiary structure. Because nowadays that predict the tertiary structure of a protein, one can use the AI, which in a very short. Yeah,
of course, you're right.
That should be okay.
No, I didn't dismiss AI as a method. It's a very useful method that we are using. All I talked about is the need for regulation on one hand, and the fact that personally I want to write my own papers, and I want people to review my own papers because AI may say to me, oh, instead of, they will reject my grant or reject my paper because they say that a better assay for protein is not Lowry, but some other body. So I think that people have more sense of reason. They say, oh, Aaron published already 300 papers that I cited in the literature 120,000 times. Probably he knows what to do. I don't have to tell him which protein assay to use or not to use. I think that people will be more sensitive to the context, while AI is very technical. You know, he will say, oh, the current assay is this one, so maybe the grant should not be funded, and so on. So I didn't, on the contrary, I think that AI is extremely useful. But I think that AI should leave something for us as people to do, otherwise we can go home.
Yeah, I think that's a misunderstanding. So if you're using AI try to predict the protein structure, I think AI is a very good tool. I think what his original comment is the concept. If you want to ask a question, that original concept should not come from AI because AI will not help think. But using AI as a technology to collect the information, to determine the tertiary structure and so on, and which is a good thing. Yeah, which is a good thing.
Yeah, I hope that process is our thinking process. Yeah.
Okay, then there's another. Oh, you want a question?
Yes, I do have a question. I think it's a very important question. My name is Liao. I'm the professor of medicine. So I think there's quite a few undergraduate and graduate students in the audience. And would you please give these young talents some advice so in the future they may have the chance to become as outstanding researchers as you are and even win a Nobel Prize in the future? Thank you very much.
Yeah, I was asked the same question in the interview that I had by a journalist. I don't know whether she's here or not beforehand. There is no really good advice that I can give. I can give something of my own experience. I lived only one life. I lived my own life. I cannot talk on behalf of anybody, and I don't think that I'm smarter than anybody else. I think that today people are living very short-term life. They have little machine called cell phone, and they read the information in the cell phone. Until recently, they used Wikipedia, but Wikipedia is too slow, so now they can use ChatGPT or Perplexity or I don't know what, or deep scan, deep whatever the Chinese now put into the market. And they can ask questions, but the questions are not answered really deeply in a good way because they are written by people. It's not really a book that was written by a person that went to the library based on science and so on. So there are many mistakes there, and so you cannot learn much from them, and people want immediate answer that will not take them more than 2 seconds to read, because if it takes 3 seconds, they lose their patience, and they don't want to listen to it anymore, and so on. If I look at my career, I can tell you that there was no a eureka moment. There were a few eureka moments in the lab that I found something interesting, but it was hard work and long target vision. I lost my parents at a very early age, so I had to work for my life. I was a little bit involved in criminal activity, was sitting in jail a little bit, so that doesn't matter. Then I went to medical school, studied 7 years. Then I went to the military, served as a combat physician. Then I went to do my PhD. Then I went to do a postdoc. I did everything with my own bare hands, always looking into the future, and nevertheless I didn't miss anything. We got all the prizes in the world that I couldn't care less about them, because I still continue to work in the lab. I'm still enjoying science, I'm enjoying teaching and educating. I think that the idea is to do what you really love to do, with the knowledge that it may not bear fruit tomorrow or in the next minute. It may take years to bear fruit. I didn't jump over any step. I didn't jump on class B in order to get to class D. I did all the 12 years of high school and elementary school. I did everything on time, and nevertheless, I managed to be successful. So, but the idea in life is not to get a Nobel Prize. This is a wrong idea. If you dream about it, forget about it. The idea in life is to do something meaningful, to contribute to society, to be a good citizen of the world. And I think that the good advice that I can give people, which I took to myself, because I switched from medicine to science, which was not easy, to make a decision to leave the operating theater and to go to do a PhD where I didn't know what is a pH. I didn't know anything. I didn't know what is molar. I didn't know what is a solution. I didn't know anything. And I went directly to biochemistry from the operating theater. So it took me a long time to educate myself and to bring myself to the basics of it all, understanding what is chemistry, and what is biochemistry. But I think that the best advice that I can get is choose for your life something to do that will be also your hobby. People are asking me what is my hobby. So I ask, what do you want me to do? To collect Taiwanese stamps? What do you want me to do? To play the piano? It's very nice to play the piano. I really admire pianists, but I enjoy more listening to the piano and doing my work and reading scientific paper than to go and study and playing the piano, because I'm not good at it. I'm simply not good at it. So my hobby is what I do, my science. I think about it, I live it, I dream it. I think, and there is a stupid university in Israel called the Technion that every month put a check in my bank for my hobby. Every month, for the last 45 years, they put a check in my bank in order that I will play my games. So, and I enjoy it every day. I'm surrounded by very young people now, all my graduate student postdoc, that are far smarter than I am. They are reading a lot. We have lively, stormy discussions. You know, we are changing ideas all the time. And I'm doing what I love to do. And I'm good at it. I know that it's, you know, in the tips of my fingers. So I think that the idea is young people today, especially because they are influenced by this telephone and the networks and Facebook and Twitter and all this bullshit, they are under huge pressure. So you know, you have to excel here, and you have to pass the exam here, and you have to get to the best university, and your parents want this, and your aunt wants this, and your girlfriend wants this, and everybody wants something for you, and you don't know where to go. I think that the idea is to shut down all the noise background, all the background noise, and to listen only to one voice, to your own. What you are good at, what you really feel that you will be successful in. You want to be a ballet dancer? Go to dance. You want to be an architect? Then don't become a biochemist, because you will fail as a biochemist. If you're not good at it, you will be just one of another million and publish one paper in JBC and nobody will remember you ever. So do what you really feel is making you happy and you're good at. Because then you don't have to retire. You know, I'm 78 now, I'm going to the lab, I'm doing what I want to do, I'm traveling the world, I'm enjoying life like hell. So, and nobody can stop me. I do what is in my imagination, I'm running lab with smart people. You can do whatever you like and still enjoy it. And that can take you, the idea is not that my university allows me to work beyond pension, because I'm not going to pension. The idea is that you can do the same thing for decades without getting bored. Because most of the people get bored in what they do. When they come in the morning to work, the one instrument that they use all the time is this one. They look for it and they want to accelerate it, like they want to accelerate the proteasome, so 4 o'clock will come very fast so they can go home and look at the television. So the idea is that you can do things for decades and still not getting bored and enjoy it. And the only person that can answer such a question for each of you is you yourself.
Yeah. Okay, so I'm going to very quickly summarize what he just said. I think for advice to the younger generation, use your heart to choose what you're interested in. And then when you choose, from his career, he actually very smart that at the time when he was young, he already identified a field where he wanted to commit it, and then that's very important. So from your heart, choose an important field and persistent. You have to continue stay there to get it done. Okay, so just use that as summary. There's some question there, right? No? No more question?
I think this was a good point too.
Okay, so time is almost right. So how about last question? Last question, and identify yourself. Last question.
Sir, myself Ali Iqbal, and I am a PhD student here in China Medical University. Thank you for sharing us a wonderful presentation, and later on share your experiences. Sir, as you told us that the people lived 1,000 years ago, they had more lifespan or the life. But nowadays we have a lot of technologies and we have a genomic studies as well. So can a person who are going to perform a baby birth and he go to any health insurance industries or the pharmaceutical industry and ask the same question, are you going to cure all diseases and what prices in my son? Is it possible or no?
What was the question, Minchi? What was the question? I didn't hear the...
Is it possible to cure all the diseases at what price? Yeah.
So your question is what? Are we going to cure all the disease?
Are we going to...
Not today, but in the future.
Yeah, this is a very sophisticated one. If we look at history, you know, 120 years ago, people didn't die of cancer. You know why? Because they didn't live long enough to get cancer. Yes. They didn't die of Alzheimer. You know why? Because they didn't live long enough to get Alzheimer. They didn't die of heart attack. You know why? Because they didn't live long enough to get heart attack. So you may argue that cancer, brain diseases, and vascular diseases are all the result of science and technology that expanded our life and expose those diseases. And this is correct. These are man-made diseases. I'm not talking about eating fats and cholesterol and self-inflicting diseases. I'm talking about diseases of aging. These are all diseases of more advanced age, of failing of systems that we caused by expanding, but nobody will give up on living long, right? We are ready to live with this punishment that in the world cancer and Alzheimer and vascular diseases are circulating. What is behind the corner if we shall cross 100 or 110? We don't know. I don't believe that there will be, new very big entities, because we know the genome, we know the functions of the gene. Remember, we still don't have a cure to neurodegenerative diseases, so we still have to tackle neurodegenerative diseases. We still have no clue on psychiatric diseases. We don't understand behavior at all. Think about autism. We call it a spectrum, a nice word, but we understand nothing in this spectrum. We don't know the defect. We don't know the cells involved. We don't know anything about it. We just talk blah, 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 and we know nothing about it. So there is a lot yet to be done. You may call autism not a new disease, but for me it's new because we have nothing to do about it. We don't know anything about it. Nothing, zero. So there is still to be done. And then there is a question of economy. First of all, how long we want to live. I'm not sure that people want to live 250 years. Maybe they won't. I'm not sure, with all these diseases and so on. And then think also on the working market. The long life already created a huge economy problem because you are saving your pension, okay? You are saving for life. Actually, when I go to pension, I'm actually living on my own saving or on the pool of savings of other people. But the longer you are and the less you are working, the saving cashier will shrink and there will be no money for people to pull out. Not only that, but at least nowadays, in the last 3 or 4 years of your life, not mine, we are spending about 80% of the health expenses compared to all what we spent in our life. And that becoming heavier and heavier. Until now, I'm 78, I didn't spend anything. I got few shots. I broke my hand once. I used, I don't know, maybe a few $100s of health insurance, and I paid hundreds of thousands of dollars for my health insurance, and I spent nothing. But time will come that I will take the whole cashier and will burn it. Hopefully not. I hope to die in a road accident or whatever and finish it in a nanosecond, but it happens so that in economy, people are spending 80% of their health insurance on not health insurance, the health insurance of everybody. And again, the cashier gets emptier and emptier as lifespan is increasing. So this also imposes a real issue on diseases and so on. Also, it turns out, that's the last one, that despite the fact that people can live very healthy, at the end they die. And they die of a sudden event. Take marathon runners or people that are exercising all the day long. They reach 95, 97, and somehow they pass away. So probably even without diseases, the chronic diseases, there is an end to the ability of biological system to sustain life for beyond certain limit. So I think that God, whoever God is, I don't know who he is, created us, I would say, in a clever way. We are trying to manipulate him a little bit, but to a limit. So I didn't answer your question, but I thought that I gave it a little bit of an umbrella.
Sir, thank you so much. It's a wonderful answer. And in the end, you definitely say very right that God definitely set something in us. And because in my mind, I think the diseases will change after 100 and 120 years. So right now we are facing cancer and some other disease and we are treating it and we want to prevent it more. So in the next 10 to 100 years, the more diseases will come and we will...
Maybe there will be more diseases. Yeah. I don't think that there will be big entities that we haven't identified yet.
Okay, I would like to take this opportunity that before we give our friend Dr. Ciechanover that a big applause. That thanks for your staying, and I hope that you enjoyed today's discussion and the lecture. And then now let's give Dr. Ciechanover
Another big round of
to
applause.
show
Yeah.
the Taiwanese passion so that in the future he will come. Thank you. And give another applause for yourself who stayed at the end. Thank you. Yeah.
So the Nobel Laureate